we started off with Marianne saying how community health is where it's all happening, and I agree with that. I think we need to take a leadership role as oral health professionals ourselves. I don't think we can rely on other professions always coming to us. We need to go out and do that. I think we're getting encouragement from politicians and policymakers. It's not always clear that we are being, and those words that Marianne said yesterday seemed to be quite encouraging, and I thought that was a really positive move. Where's John? John Rogers, there he is. He sort of gives us little tips that the political wind might be in our favour a little bit, but we do feel quite isolated sometimes. If we can't do it in community health with the co-located services, imagine how hard it is for private practitioners who are more isolated than us, isolated professionally and physically. So I think if we can't do it here, what hope is there really? So we need to understand that we are the petri dish for these sorts of ideas. We're used to working in a team approach. We work with the different dentists, therapists, hygienists, prosthesists, and we should be able to quite easily transfer that to occupational therapists, speech therapists, and all the other allied health people that are around. And I think we are quite good at client-centred care, which is a theme that came through yesterday and today, that if we're not taking if we're not recognising clients' needs and not listening to them, then nothing's going to happen positively anyway. So what can you do? What can you do? And I've had a little think about that. And John Furley yesterday said, well, those little small trials are actually quite instructive, and there's something that we can do. You may have a oral health educator or a therapist who might be able to just go and work with a diabetes educator. It's not a difficult thing to do. We've demonstrated that. Lulu talked about that yesterday. Or go and talk to your GP and say, how can we help you with what you're doing? And if something small can inform the bigger picture, and that's also something I think that we can do. It doesn't have to be a university-based trial, but I think just practice-based trialling things out is really important. And so make that effort to go and meet the people. Sometimes you don't even know who the other health professionals are in your building. Even this place, which is quite small, you keep bumping up against someone who you don't quite know what they do. So you need to actually go out and I think take that initiative again. Sharing knowledge is always going to be important. Collaboration is the first step. I mean, integration is obviously the holy grail, and that's very difficult. Deb's already discussed, I guess the thing that holds us back is the productivity issue. Those damn DWAs, if we if we feel don't have the money or the resources, then we're going to be more afraid to take chances and do things differently. So we need to solve that problem, and look, encouraging words from Deb that really an outcome-based funding model would be much better. And then we've also heard about the medical model, which is a capitation on chronic illness. And that might prove to be quite a funding model that might be useful in dentistry as well. We'll wait and see. So I just want to run through some of the things that we've done, which I know more about. So we've had a smoking cessation program with Alison, and I've just put down this. I heard we talked about role diversity this morning, so I thought demonstration, oral health therapist gives the smoking cessation. Lulu, who's a dental assistant, moved on to oral health education doing the diabetes. Vang, who's a hygienist working with the GPs, working on their team care plans and physically stapling an oral health plan to the back of it. And first of all, and it wasn't really discussed, John mentioned it yesterday, but the just having someone there to discuss oral health, it increases the knowledge, as Wang was saying about the pharmacist. GPs don't know anything or know very little. So just having someone there to bounce ideas off and educate them, improve their health literacy, I think has a really powerful effect. Working with the child and health nurses, we're lucky we've got them in the same building. So they're sending up people, their families for 1-year-old checks. So they've caught on that, yes, it's about 1 year, not 2 years or 3 years, or when at some later date. And we've got the people who inject drugs. That's an ongoing program with Emily. Anna started it, Anna's a hygienist and Emily's an oral health therapist. And that's just about providing access to those people so that it's what I think we heard was a warm referral. So we would get the caseworker or the drug safety program person would bring the client up and say, look, here's someone that needs your help, or here's the appointment, let's not make any more barriers. So it's working with other people like that. And I think with these small projects, they really engage the staff, they spread the message, and about retention, so people are more engaged, it's more interesting work, it's not just sit down there, drill, fill, it's about health promotion. And it also usually involves professional development. We sent, Alison went to the respiratory health course at the Alfred Hospital, which was a serious 2-week course. So she becomes highly skilled, not just how to do quit, but it's a real proper process. So now what are we going to do? Now, the first thing I'm going to do is find out our pharmacist and invite him to our place so that we can. There's probably more than one. I know there's a couple, but I don't know their names. So, there's a shame on us that we haven't done this before, and it's a great first thing we're going to do. Zora's not here, but yesterday she raised the issue of private dentists. Are we going to just forget about them? But I don't think we can. I think we need to invite them into what we're trying to do. We could hold meetings. We could just have those discussions, and just professional chats, if nothing more. But they probably don't know what's available in this building. The local dentists probably don't know there's a drug and alcohol program, there's all these other programs. So that would it might engage them more in the whole public health issues. There's also the engagement with our internal providers. We have a clinical meeting, it's a multidisciplinary, and I mentioned it yesterday, but that will be reinforced by this conference, where there's a care coordination and internal referral review going on at the moment, and I think we'll be talking to Peninsula Health about how they might be able to help that process. That was I was really impressed with that referral process. So that's number 3 or 4 on the list, but it might go up a bit higher because I thought that was really impressive. We're hoping to work with the autism and oral health program. Marcella and Jane, Jane's an oral occupational therapist, and our dental therapist. And I think there's that with the NDIS coming on. I think that's an area that we could develop here. Now, dentures and diet. I would like to take 10 of our clients that get new dentures and refer them straight down to Nardine and give them some dietary education. The evidence is clear that we can give people new dentures, but they go back to eating the same old food. They come in saying, I can't eat, but they need that behavioural change. So I think there's an opportunity for us to combine dentures and dietitians together. And I think just to continue to be opportunistic, I think that's really the way forward for us. Now, I think sharing information and research, advocacy. I think last year we had the mind, this year we had the body, and next year we could have the soul. So, watch this space. And talking and sharing, and this is what the conferences, I think this has been another example of networking, sharing information. I think there's a sort of a positive vibe and an optimism that comes from these meetings. And to be disruptive, we've got Jamie, he's always disruptive. Natalie, Michael, and I think we need to challenge the status quo. I think some of the policies are wrong and not really helping in client-centred care. And I won't give examples, but you could probably all think of something like the waiting list policy. And I would like to develop an aim for our program, which would be to develop an integrated model of care which is evaluated and can be used to demonstrate that it is possible to put the mouth back into the body. Hopefully I can report back next year. So thank you very much.